after that, on 23rd March, we have our next lecture of bone and soft tissue pathology on approach to bone tumors by Dr. Mukhtar Amadwar. So,
okay. Right. So today, as you know, we're going to talk about a contemporary hematopath lab approach on acute lymphoblastic leukemia or ALL. We have a workshop going on in our lab right now, so please excuse me if I sound tired. I was here till the morning. So let's see. Okay. Just give me one minute. It's not moving. Okay, so we have students today as well. So Shivangi, can you tell me what's going on here? Like, what do you think about these cells that you can see in your screen? What about this? If I can start with this cell.
Here we can see a cell with high NC ratio and high NC ratio with the scant amount of cytoplasm and prominent nucleoli as well. So,
okay, so which one is the prominent nucleoli I'm talking about? This thing you were saying as prominent nucleoli?
Yes, sir.
Shivangi?
Yes, sir. Yes, sir.
Okay, so like compared to the blast that you see, for example, let's say this blast and the nucleoli that you can see, which is very prominent. Do you think that this is this cell has very prominent nucleoli, or you will consider this to be inconspicuous?
It's inconspicuous nucleoli, not prominent.
Okay. What about this? What do you think about these cells?
So these have more amount of cytoplasm with the chromatin is a little opened up compared to the other cell, and they don't look like blasts.
Okay. Okay.
Don't look like this.
What about this cell? I think now.
So these have similarly high NC ratio. The cytoplasmic extension also looks like and with minimal scan cytoplasm, giving an appearance of hand mirror cell specific.
That's correct. Cells. That's correct. So this is the kind of cell we usually describe as hand mirror. So it's just a descriptional term, nothing more than that. What do you think about these two cells? Maybe I can ask Sonam now. Sonam, what do you think about these two?
So these are blast cells.
Cases. Okay.
These have vacuolation in cytoplasm, and basophilic cytoplasm is there, and high NC ratio, and it could be L3 type of ALL picture.
That's very good, very good. And what about this case? What do you think? This is the peripheral blood. So what do you think about these predominant cells like this?
These are erythrocyte precursors, maybe.
Why do you say they're erythrocyte precursors? Anyone else think differently? What do you think, Sonam?
Sir.
I was asking you only. So what do you think, Soumya, about these cells? First, tell me, do they look like erythrocytic lineage, or do they look like lymphocytic lineage?
So lymphocytic lineage.
Okay, so yes, I agree with you. For erythroid, like we had basic morphology classes. So in that, what will happen is you will have a very dense nucleoli usually, and the cytoplasmic color will start mirroring those of mature RBC. So if these are actually your erythroid cells, so they are very immature then, right? Because the cytoplasm is very less. So if that is true, then you should have a much more opened up chromatin. So this doesn't look like erythroid cell to me. This look lymphoid cell. So then if it's a lymphoid cell, okay. So now now that we have discussed all the 6 images, so which of them you think are lymphoblast? Which of them you think are normal? Which of them you think could be myeloblast? Shivangi, and which could be mature lymphocyte? All of them look blast to you, Shivangi? All the 6 pictures?
No, sir. So the last picture shows normal lymphocytes.
Right.
Yes, sir.
So let's not make normal versus abnormal distinction yet. So this looks like mature lymphocyte. That's what you mean to say, right?
Yes.
Yeah, and the rest all 5 looks blast to you.
This the one above the maybe the last of the first row looks a bit like maybe hematogones.
This guys you're thinking this cells?
Yes, sir. They don't look like.
Okay, and what about these two? Like, do they look lymphoblast or they look more myeloblast to you? These 2 cells, and sorry.
Lymphoblast. They look like lymphoblast.
Okay, so yeah, you are actually right. So in this case, all these 5 pictures, there is one case with hematogones. I'm not really revealing yet. We will see later on. But these are no myeloid blast seen in this picture. So sometimes lymphoblasts can have vacuolations. Sometimes they can have much more cytoplasm, much more prominent nucleoli, which are usually features that we typically associate with myeloblast. So, but that not necessarily means it will only be a myeloblast. Lymphoblasts can have that kind of morphology, right? So, what about these 3 images? You want to make any comment? I think we have not asked Yogita. Yogita, what do you think? These 3 cases, what do you think they are?
So picture number 1 shows
yes.
leukoerythroblastic picture showing immature WBCs and nucleated RBCs.
This is a marrow. Why do you say leukoerythroblast?
So,
This is
sorry,
a
sir,
marrow.
normoblast.
Yeah.
Normoblast.
Okay. And do you see any blast cells? What about this?
Sir, these are lymphoblasts, sir.
Okay. And what about these two cells?
Sir, normoblast.
Right. So now I think Sonam said erythroid, right? So can you see the erythroids now, Sonam? So they look completely different, no? Their chromatin is different. They are much more centrally placed. So these are erythroid cells. This cell, like Yogita said, this is a lymphoblast probably. Okay. What about this? Yogita?
Sir, this is a picture showing one normoblast and many lymphoblast cells.
And what about this? This is
Sir.
peripheral blood, let me tell you.
Yes, sir. Okay, sir.
Yeah.
Sir,
So what do you think about this?
these are lymphoblasts, sir.
These are lymphoblasts. So do you want to make any comment on the disease then? So according to you, these two cases will be ALL then, right? Because they are all lymphoblasts, you said.
And
Is
sir,
it
in
true?
picture number 3, sir, according to sir, age criteria, third picture is for CLL, sir.
Okay, so I've not given you age criteria yet,
Sir,
but
next
okay.
slide, sir,
Okay,
next
okay.
slide.
Okay, and what about this? What about this? Do you think this is leukemia? What is going on in this?
Sir, this is simple leukoerythroblastic picture.
Again, this is marrow. So of course you are just looking at normal marrow is what you're saying, right?
Yes, sir.
Okay. Okay, I think I have to get rid of the laser because it's not moving. Okay, you can still see my pointer, right?
Yes, sir.
Okay. So, now I give you the history, which like Yogita already knew. So this is an adolescent male with a short history of fever, and we are seeing an adequate megakaryocyte and erythroid, right? So then the point I'm trying to make here is this is lymphoblast, you said. Yes, this looks like a lymphoblast, but when you put it in the overall context that the overall marrow looks normal, so this doesn't look abnormal then. So the point is that just by looking at a single cell, you should never be diagnosing conditions. Actually, if you go back, this is the same cell as this. So this cell is what we saw initially in the initial pictures. This is the same cell here, right here. And when I give you the history, you see that the normal maturation was completely there. So this is just probably a normal hematogone, normal lymphoid precursor. So then this case can be diagnosed confidently when you look at the whole marrow and the whole clinical context. Whereas this is a girl child with a short history of fever, there is cytopenias going on, and the complete marrow is wiped out by this blast-like cell. So now there is no problem at all diagnosing an acute leukemia. And this case, like Yogita said, this is an older adult male with high TLC in the peripheral blood. The platelet you can already make out in this picture that they look quite normal in the peripheral blood. So this was a case of CLL. So some of the cells had a little bit of opened up chromatin. So sometimes on morphology it is really challenging, especially if you are dealing with an L1 type of morphology. But the point is that debate is academic, because if you put the clinical context in picture, like this is an older adult with this kind of picture, so then you can probably safely suspect a case of lymphoma rather than a blast-like picture, right? So look at the individual cell morphology, but always interpret in whole context, like whole clinical context as well as whole morphologic context. So with that, let's just say that an ALL diagnosis depends on a constellation of findings, including clinical history and morphology, like we saw right now. Then we will see that immunophenotyping, cytogenetics, and molecular techniques, how they help in ALL diagnosis. So an ALL diagnosis doesn't occur at today's date with only one of these things. You have to take into account all the finding from all these things. So now we can go to case 1. Shivangi, can you start?
So here's a case of a 12-year-old male presented with fever and a cervical lymph node measuring 2 into 2 centimeter. Hemoglobin was 13.1 gram per deciliter with TLC 7.5 into 10 to the power 9 per liters and platelet 220 into 10 to the power 9 per liters.
So what is your impression on the count?
So
what does it look like?
They look normal.
So it looks like normal count, right? Okay. And then?
So then we had an upside and it showed 25%, and this is of leukemia. And further it was followed up in TMH.
Okay. Let's go into the pictures now. So this is a low power picture. What will you make up of cellularity in this case, Shivangi? This is a 12-year-old girl child, remember? Sorry, 12-year-old boy. So what do you think?
So it looks normocellular, sir. Normocellular to hypercellular.
Okay, I will not say hyper because it's a 12-year-old kid. So the fat spaces are there. So it's not hyper. But I agree with you. It looks like a normocellular marrow. And what about this cell? What is this? Okay, megakaryocyte. Nice. And what about this field now? Do you want to describe any particular cell? What about this cell? What do you think these are?
So I can't see the laser, sir.
It's not laser, it's a black pointer now. This one. You can see my pointer, right?
Yes, sir. Now I can see.
Yeah.
Yes, sir. So they are erythroid series cells, sir. Normal.
Fantastic. Fantastic. What about this cell? This one. What do you think they are?
So it's still pointing at the. Okay. So they are myeloid lineage cells, sir. Myeloid.
Correct.
cells.
Correct. So we saw megakaryocyte in this case. We saw erythroid, and we are also saying myeloid lineage cell. Okay. So now, do you want to go to this cell? What do you think this is?
This looks, yes, sir. So this looks like lymphoblast, sir, with high NC ratio and
Some
maybe
nuclei as well. Yeah, so I would not probably call them lymphoblasts. Means you can say they are blasts. On morphology is very tricky to sometimes decide between lympho and myeloblast. So we till now let's call them only blast. Okay.
Yes, blast.
What about these cells? 1, 2, 3. What do you think?
One above.
Shivangi, I think I'm losing you in between. Is it only me or her voice is breaking in between?
Yes, sir.
Her voice is
Looks
breaking.
like a myeloid lineage, but the others are. Sir, am I audible?
We lost you in between, Shivangi. So what do you think about
Am I
these three
audible now,
cells
sir?
again? Yes.
So
much
they
better.
look like lymphoid lineage cells only, so blast.
But would you
Blast only though.
consider them as mature lymphocyte?
No, sir. Blast. They look immature, sir.
Okay. What about these three cells again? Similar morphology, right?
Yes, sir.
So high NC ratio, the chromatin is much more opened up as compared to normal lymphocyte. But you are correct when you said that they look lymphoid lineage. Like if you compare with some more maturing lymphoid cell like this, their chromatin seems to be almost similar, right? So they are slightly more opened up, but they looks almost similar. So probably it will be safer to suspect, reasonable to suspect lymphoblast in this. Okay. So in the fields that I've shown, it looks like this blast proportion probably account to almost 30% of all cells. So surely the blast is more than 30%, right? So what is your opinion on morphology and the overall morphology, Shivangi?
So I would suspect it to be lymphoid lineage leukemia, so acute leukemia.
Okay. And why do you say so? Because there is more than 30% blast, right?
30% blast, yes, sir.
Okay. So what is the cutoff of blast percentage you usually take to diagnose acute leukemia?
So 20%, more than 20%.
Right. So there's no strict criteria in lymphoid lineage, to be honest. It's more of a myeloid lineage criteria. But you're right, 20% is what we take usually. So what do you do next then, Shivangi? Are you going to diagnose only on morphology?
No, sir. So we could do for cytochemistry, sir.
Yes. Very good. Very good. What did you see in cytochemistry?
So we may start with MPO and it will come out to be negative for the lymphoid cells, lymphoid lineage cells. And if we move ahead with PAS, it may show dot-like.
So these are only assuming that they are lymphoblasts, right? So you will do MPO, you said. So what if MPO is negative? What will you do? There is nothing in PAS. PAS was not done, let's say. So then what will you do next?
Then we will move forward with immunophenotyping, sir.
Can you on the basis of MPO negativity diagnose acute lymphoblastic leukemia?
So we may say MPO negative acute leukemia. We may categorize.
Why? Why so? You're right. Why so? Why not straight away call acute lymphoblastic leukemia?
Because many like M4 and M6, they may also be MPO negative.
That is true. So there is a lot of AMLs which can be MPO negative. So on MPO, we can only say these are MPO negative. If it's positive, we can safely say it's AML, or at least there is a myeloid component to it. But if it's negative, we cannot really say this is ALL. We have to say this is MPO negative acute leukemia, right? So then you will go ahead with immunophenotyping. So this is what we did. This is our panel. So I'm not really going into detail about that. We will see the relevant markers as we go along. So this is the flow cytometric plot. Shivangi, can you read this for me? So what do you see in y-axis? What do you see in x-axis? Shivangi, you're there?
On x-axis, we are seeing a site scatter. Yes, sir. X-axis, no. And on the y-axis, we can see CD45.
Right.
And,
so this is generally your first plot. Means like after you get viable cell and singlet, this is generally your first plot to identify the predominant cells. So here we can see three definite clusters for sure. So these cells are 45 bright and low side scattered. So what will be these cells, Shivangi?
45 bright and low side scattered. These may be mature lymphocytes.
Correct. So I'm talking about the blue cells. So you think they are mature lymphocyte? You are absolutely right. What about these cells who have quite high side scatter and 45 appears to be dimmer? So what are these cells? The green ones?
So they are granulocytes.
They are granulocyte because they have high side scatter. So side scatter usually denotes complexity of the cell, like including cytoplasmic granularity, nuclear complexity. So we know that granulocytic lineage has high side scatter because they have high granularity and much more complex nuclei. What about these red cells which occupy a zone that has 45 dim expression and side scatter low? So what do you think they are?
So they are blasts. They show them
that is true. So this is the blast zone. Now, does it mean that only blast cells can come in this region? No. There are some mature cells, like we have discussed this in our flow cytometry class. I think there can be basophils, there can be PDC, there can be NK cells. So a host of other normal cell can also come. But when it is so much expanded, so here you can see it's almost 51%. It's probably at least precursor cells. Some precursor cells are here. You are right. So now that we have identified our blasts, which are these red cells, now let's follow only them and identify their expression pattern. Okay. So what do you think about CD19 and CD10 in this plot, Shivangi?
CD19 and CD10 are positive for the
in the
precursor
blast.
cells.
Correct.
Yes, sir.
And what about CD34?
So CD34 is also positive, sir.
Okay, so is there a difference between this 10 positivity and 34 positivity? Even
Yes, sir.
yeah. In IHC, it is difficult to say it's like that because in IHC you can only opine on positivity and negative. But in flow, because we see individual cells, so it is good to describe like what is the expression level. So what according to you is different in CD34 and CD10 expression in this case?
Sir, in the first, okay, sir, 34 and 10, sir, it's showing dim to moderate positivity, sir, for CD10 and 34.
Okay, so in 10, what I will say is this is very homogeneous, right? So 10 expression seems to be positive in all the blast. Whereas 34, it looks like that a significant portion of blast is negative and only a portion of blast is positive for 34, right? So it looks like a heterogeneous expression or a partial positivity. Would you agree with that observation, Shivangi? Yes. So it looks like 34 is gradually lost and 10 is still positive. So in this, the gates that I've drawn, so these are drawn on normal B lymphoid precursor, or those cells that we know as hematogones, because they have a typical immunophenotype. So the gates are drawn on that. So what I see is that the cells follow these gates quite nicely. Let's go on and see other things. What about this, Shivangi? What is the 20 and 45 expression according to you?
So 20 and 45 is also so moderately positive.
Yeah, they also seem to be heterogeneous, right? So this is the blue cells, as you said, are mature lymphocyte. So this is probably mature B lymphocyte. And 20 and 45 seems to be heterogeneously positive in our blast. Okay. So even in 10 and 45, we see that they kind of follow the pattern of the hematogones. This is again a 10 and 20 plot. We have seen that 10 is homogeneously positive, but 20 is variably positive or heterogeneously positive, right? And do you feel like that these are the cells that go and ultimately become mature B cell? Can you see a connection between these cells and mature B cells?
Yes, sir. There's a maturity pattern that's showing.
Yeah, so it looks like that these cells are kind of maturing towards mature B cell. I can see a nice maturational pattern. Now, some other markers we did like 86, even we did 73. I think these are some aberrant markers. They usually come in B lymphoid blast, but they are always negative on hematogones. So those markers seems like those are negative, right?
Yes.
Again, this is a very important plot, CD10 and 38. So what do you think about the CD10 38 expression of the this blast, our blast, CD10 positive blast?
So 10 is bright positive.
And even 38, right? So even 38 is very homogeneous. So it looks like 10, 38 are co-expressed. And finally, both of them are lost and this becomes mature B cell. So again, that pattern that we discussed, it seems like it is maintained even here. So, in B lymphoid blast, a very important anomaly that we see is 10 positive and 38 negative. So usually B lymphoid blast can be somewhere here. But in this case, looks like 10 and 38 pattern is mirroring that what is seen in normal. Now, this is some lineage, some cytoplasmic markers. So we did MPO, which is a myeloid lineage marker, which is negative. Cytoplasmic CD3 is a T lineage marker that was also negative. And some B markers like 17 alpha and 22 was positive, right? So, so what do you think about the lineage of this blast, Shivangi?
Sir, after all these flow graphs, we can say, sir, that it's B lineage, sir.
B lineage. Very good, because then the negative for myeloid and T markers, and they express all B lineage marker. Very good. So if that is so is it a BLL then? Can I diagnose this case as a B lymphoblastic leukemia?
Yes, sir, but we can further do testing.
That is fine. So anyone else think anything else? What about you, Soumya and Sonam? What do you think?
B lineage, BLL, sir.
B lineage, this is two different things. One is the blast R B lineage, and the second is this is the case of B lymphoblastic leukemia. So you agree with both this statement?
Sir, it's a B lymphoblastic leukemia, sir.
Okay, and what about anyone else feels anything different? You can write in the chat also if anyone else feel anything different to this. What about you? Sorry, I forgot the name. Yogita was right?
B lymphocytic leukemia.
B lymphoblastic leukemia. Okay, and you, Soumya?
Sir, I also think the same time. B lymphoblastic leukemia, sir.
Right. So the diagnosis.
Dr. Gaurav, a few of our attendees say.
Yeah, I saw that. So the actual diagnosis is this is just proliferation of normal B cell precursors or what is known as hematogon. So like I said, there is two statements. One is these are B lineage. Sure, definitely they're B lineage precursors. But is it leukemia? No, because this looks like normal, right? We saw that they're completely following the normal pattern. So let's discuss a little bit about the normal maturational pattern, which is extremely important when you are doing flow cytometry, right? I think this is an area which is often under discussed, and we give more importance to blast positivity of this marker and that marker. But it's very important to recognize we can see a very good maturational pattern when you use flow cytometry. So for example, here you can see I have used 6 to 7 markers and created a beautiful maturational pattern. So these are some uncommitted precursors in red. The sky blue is when the first B lineage markers start to appear, and then they become hematogon 1, hematogon 2, finally going up to mature B cells. And if you then chart the expression of normal markers, you can create this kind of maturational map. Okay, so here the green means positive, and the more red we become, more negative we become. So as you can see here, some markers like CD10, let's say CD10. So it is initially negative, then they become nicely positive, and then again in the mature cells they become negative, right? So that is how the maturation occurs. We will understand them more with individual plots. So now if you see these plots, let's say this 10 and 20 plots, okay? So these are the uncommitted precursors. Like I said, the red cells are uncommitted precursors. There is no indication yet that they are going to become B cells. But when you see these sky blue cells, they have started acquiring CD10. So this is what is known as pro B cells or very early B cells, even before hematogon 1. And then this orange cell is hematogon 1 or the first stage of hematogons. The green is when it starts to appear CD20 or what we known as say hematogon 2. And the blue cells are some transitional B cell, which still has 10, but the mature marker 20 and 45 has come. And finally, they lose 10 and become the naive B cell or the mature B cells. So, it is not important to identify, to remember all the subsets and what is the phenotype of all the subsets, but it is very important to identify that you can see this nice maturational pattern within the context of different markers. If you choose the maturational marker, like here also you see 34, 38. So lose 34, gain 38, and then become like this, and again lose 38 and become mature B cells. 34, 20, they lose 34, become 34 negative, 20 negative, then gain 20 and become mature B cell. So the point is that normal maturation, not only B cell precursor, even if you see myeloid and other maturational, they will follow a well conserved and predictable pattern of antigen expression. So the concept here is that when any cell mature, there is a predictable pattern of antigen loss and antigen gain. So for example, when they are maturing, there is a predictable pattern of 10 gain and then 20 gain and then 10 loss. So this pattern is predictable. This will happen in all cases when you see normal marrow, right? So what is the importance of this? So this is some other patterns only, so I'm not going to detail, but the fact is that they follow a very well conserved maturational pattern, normal maturation using flow cytometry. So how we can use them? We use them in this way that when any blast is abnormal, so like for example, we are looking at morphology, there are some clues that this blast can be abnormal. Similarly, in flow cytometry, what we look at is aberrancy. So how it is different from my normal B cell precursor. This is a very good way of looking at flow. Don't look at only what is positive and what is negative. Look at in that way that how it is abnormal, how it is not fitting into my normal spectrum. So for example, here the gates that I have drawn, these are based on normal hematogon. So you can see that 73 definitely looks like it's going outside the gate. So it is abnormal. Similarly, 86 here is abnormal. So this is how we know that B lymphoid blast always will have some abnormality as compared to their normal counterpart. And this can be used at MRD time point as well. Here you can see that some small dots, small red dots, these are actually the residual leukemic B blasts, and they again fall outside of our normal pattern. And this orange, green, and blue cells, these are our hematogon 1, 2, and 3, 1, 2, and mature B cell, and they follow the normal maturational pattern. So in this way, you can easily separate what is normal maturation from some abnormal B lymphoid blast. So now that we have seen in our case, yes, sir.
So I'll just interrupt for a minute just to tell you.
Yes, sir.
Please. That I think this is one of the most important things in today's talk, how to recognize the normal from the abnormal, and it is becoming increasingly critical. This is since all decision making now is based on flow and MRD, and picking up even small population of abnormal blasts, this distinction has become critical. And next thing to add on to that, with the availability of immunotherapy, where some of the markers now start disappearing within the normal hematogone. Supposing you use CD19 directed therapy, CD22 directed therapy, or then CD20 directed therapy. So even in this normal maturation pattern, we see abnormalities in the sense that they are normal blasts or they are normal hematogones, but they are not expressing even these markers, for example, CD19. So one has to now learn how to interpret hematogones with the loss of some of the normal maturation markers. So it's becoming even more complex. So I think this is very, very important right now, what we discovered for the point of all your future pathologists and